feeding orally first of all possible, or enteral if the case so warrants. All right. Well, there will be times when the person's not safe to eat. There's a contraindication to feeding them into the GI tract, so our next decision that we would make would be to feed them parenterally. Definition is to provide a patient's required nutrient needs in a fluid volume that is well tolerated via a vein. I promise if you do 1, 2, 3, 4, 5, 6 different rotations, you're going to see probably one of these acronyms in each different rotation. All of these nomenclatures, all of these abbreviations mean the exact same thing. So whether it's a central parenteral nutrition, whether it is a central vein nutrition, whether it is a total parenteral nutrition, whether it's a total nutrient admixture, all of these things we're talking about feeding the person in the vein. So don't let the acronyms throw you, don't let them make you think that I don't know what that means or whatever. Just think I'm going to feed something in a volume through the vein. Generally, the indications for people who can't eat, aren't safe to eat, they won't eat, they can't eat enough, they're trying to eat, but even still they can't consume enough. If the gut works though, you have to use it. Would it be nice? Well, you know, I really don't want a tube in my nose, so just put a needle in my vein, and that way I don't have to worry about it. What happens in that particular scenario?
The gut quits working as well?
Yeah, you use it or you lose it. Have you guys ever seen a gut that atrophies? You think you had problems before? You've got major problems now. You have to keep the gut stimulated, or else all of those little tight junctions that keep all the bacteria and all the problems out, all of a sudden just dissolve, and now you've got bacteria everywhere. So you're setting yourself up for, so I think it's transbacterial relocation or whatever. You don't want that situation at all. Plus the gallbladder. The gallbladder is meant to produce or store that bile in alkaline. The minute that gallbladder doesn't have to pump anymore, what's it going to do? It's going to atrophy as well. So now you have cholestasis, and you're just got more complications than you can possibly imagine if you don't use the GI tract. You want to use it whenever you can, as little, even as little as you can, just to make sure it doesn't lay there and cause you problems later on. So that's. If you learn nothing else today, remember that dietitian that says if the gut works, use it. You can do short-term or long-term. It would require different types of catheters or different type of tubes depending on which access that how long you're going to need this TPN. Today, just about everybody, when you get into a hospital, has a PICC line. A PICC line stands for peripheral inserted central catheter. The PICC line is inserted right here. It starts here on the side of the arm, goes up and is threaded into the same place that a central vena cava would have been inserted over here, and they both land in the exact same spot. So in terms of administering TPN, it can go in a PICC line. Just because the line is down here doesn't mean there is a smaller line. The problem is everybody that goes into the hospital today gets the gets the PICC line, so they immediately start TPN and don't worry about feeding them enterally because they can use the line. Lines in your veins, guys, can lead to infections, lead to a lot of other complications. So if they could still eat orally, or if you could still feed them enterally, that would have been a better choice. Let's see if I've missed anything here. So it goes into the subclavian, which is going to go into the central vena cava. That is a huge vein. That has a major volume with a blood flow going through there. You can put large volumes through there. So, and by large volumes, you can use a larger osmolality to get the needs met that your patient needs. All right, you might want to tell me what this is? right? Words might not be spelled right, but the point I'm trying to make is you really have to pay attention. You really have to have your game on when you're going to do TPN orders. The smallest transposition of two, lipids for carbohydrates or whatever can make major errors. So if you're going to be involved in writing the TPN orders, really pay attention and really know your stuff in order to do this. I am a believer that anybody can write a TPN order if you want to. If you're involved, if you're part of the patient care, if you know your stuff, I don't have a problem with anybody writing a TPN order. A lot of nutrients go into the TPN bag. You've got your macronutrients, you've got your dextrose, which is another name for your glucose or carbohydrate. You've got your lipids, you've got your amino acids. You also have electrolytes, vitamins, minerals, trace minerals. Over 40 ingredients can be in a TPN bag. It sounds almost like a recipe. 40 different ingredients. I can have more of this, less of that. A lot of different ways to hang a TPN bag, and a lot of different ways that you can add, subtract, multiply, or divide. The only problem with that is all the tweaking that you can do can also set you up for a lot of different mistakes if you aren't careful. So this is a compounding machine that if a TPN is going to be compounded, they would set a bag. I don't know if I can see if I can. This is where they would lay a bag, right here. And then that bag will be connected to these lines, and all of these ingredients flow into that bag. It's weighed, it's recorded, and that's how you can have a lot more dextrose, a lot more lipid, or more amino acids, or more folate, all of the different things that you can add to the bag. So this is a compounding system. It's not the only way that you can do TPN. This is a more costly way, simply because it takes an individual to administer this and to record this and what have you. The opposite of this would be to buy a pre-made bag off the shelf, and that can be done as well. So there's where it starts. That over there, I believe, is the dextrose. These are all of the micronutrients. And the white stuff here is the lipids. Lipids, when you look at them, if they're hung separately, they just look like milk. It looks like a bag of milk hanging there. So TPNs can be written in two different ways. It's called a 3-in-1 or a 2-in-1. I wish it was easy as only 3 ingredients in one bag or 2 ingredients in one bag, but it's not quite that simple. 3-in-1 does contain all 3 macronutrient ingredients. It contains your dextrose, it contains your proteins or amino acids, and it contains your lipids. All 3 of those are in the same bag. It'll look white when it's delivered because of the lipid emulsion that's inside that bag. They're more expensive to make. You can tweak them all day long. You can take out a little, you can put in a little more, you can add 300 calories, you can take out 50 calories. They're, for the person that's OCD, you really like 3-in-1 combinations. A 2-in-1, on the other hand, is more the type of bag that comes off the shelf, because it's a bag that is sold as one, and down in the middle is a seam. When that seam is broken, you have equal amounts of dextrose on one side. Well, you had dextrose on one side and you had amino acids on the other side. Once you break that seal, you now have a mixture of both carbohydrate and proteins as well. What you don't have is amino acids. The amino acids would be hung, what you don't have is lipids, my bad. You could hang the lipids separately. You could hang the lipids 3 times a week. You could hang the lipids every day if you wanted a bag every day. But the 2-in-1 is cheaper, for one thing, because you can literally just buy it off the shelf. It's harder to tweak. You may not be able to meet your patient's needs as much as you'd like to, but nonetheless, it depends on the policy or the Med-Exec committee, what they want to have or what they want to offer. So this is a bag. This is a 2-in-1. There's no lipids in there. You can tell, the reason I can tell is because it's not white. The dextrose, protein, and lipids have to be calculated in order to know how many calories you're providing for that patient. Dextrose that is in a TPN, unlike carbohydrates, which is 4 calories per gram, is 3.4 kcals per gram. It's because it's a monohydrate. It doesn't have quite the same number of calories as a regular carbohydrate, and this throws everybody off when they go to calculate this, when they're learning how to calculate TPNs. So don't think 4 when you're thinking dextrose when you go to do a calculation. And it gets even more confusing than that, because the dextrose concentration can go anywhere from 5% to 70% concentration. So you can have a lot of a very high concentrated solution, or you can have a little of a very low concentrated solution. That would make a difference if you're considering the amount of fluid or the amount of volume that you need to worry about. A rule of thumb is that you shouldn't have more than 1 milligram per kilogram per minute in the TPN, and that is to help you spare proteins. As far as a distribution, we'd still like for that bag to be somewhere between 45 to 55% of the number of calories that the patient's going to receive. We'd like to use the macronutrient distribution even in a TPN bag. Proteins are 4 kcals per gram. Just like you probably learned, there's no difference there. They come anywhere from 3.5 to 20% concentration. So you could have an 8.5% concentration, you could have a 10%, you could have a 15% concentration of protein. The protein that is in the proteins are individual amino acids, and we want that final distribution range to be somewhere between 15 to 20% of the calories that they'll receive. Lipids are 9 kcals per gram. That's, as you've learned, no doubt. You can have a 10, 20, or 30% lipid, a little bit different than the carbohydrate or the protein. They're either hung in a bottle, in a 250 ml bottle or a 500 ml bottle, or they're included in the 3-in-1 solutions. So a little bit different, hang them separately, add them to the solutions. You cannot add a 30% concentration into a 3-in-1. Did I say that wrong? You cannot. You can only, yes I did. You can only use a 30% concentration in 3-in-1. You cannot hang a 30% concentration. You can hang a 10 or a 20, but the 30% is only for 3-in-1. Yes?
What did you mean by spare proteins?
If I feed 200 calories worth of carbohydrate for energy, and the body really needs 300 calories worth of energy, and I only gave it 200, it's going to take the protein calories that I gave it, and it's going to turn them into carbohydrates because it wants more energy. So if I feed the body 400 calories worth of carbohydrate, I've spared that protein to go on and do what it needs to do. So our dextrose or our carbohydrate, a lot of times those are high to spare protein. We really need the protein to heal those wounds. We really need the protein for immune function. We really need the protein for enzymes and everything else that they need to do. Any questions? Dextrose, protein, lipids? The handout is just kind of a cheat sheet. It sounds really complicated, sounds like a lot to have to memorize. You do TPNs day in and day out, and you can do it in your sleep. It becomes much easier the more you calculate. On top of the dextrose, the carbohydrate, or the lipids, we also have to have our multivitamins. We can add trace elements. There are a few medications that can go in TPN as well. So you can add insulin to a TPN bag. A lot of it may stick to the bag. It might not get into the bloodstream as much as we'd like it to. It can be done. If you think you'd rather put it in the TPN bag instead of stick the patient every time, that might be one thing to consider. If multivitamins are not added to a TPN, you can make a TPN without any multivitamins. You can have deficiencies within a 2 to 3 week period of time. So make sure that it doesn't get overlooked when the order is written. You can add electrolytes to the bag. Sodium and potassium come in 3 different types of salts. They come as sodium chloride or acetate or phosphate. Magnesium is usually infused in magnesium sulfate. We only add calcium gluconate. We don't add a carbonate or a calcium citrate to a TPN bag. We only use calcium carbonate. We have to be careful of the amount of calcium and the amount of phosphorus that we add to that bag, however. Calcium and phosphorus can form a precipitant, and that precipitant can break the bag. That means it can crack that solution. So calcium and gluconate, you do have to monitor the amounts that are in there. You may need more calcium gluconate, but you may not be able to go higher because you need too much phosphate. So you really have to watch those two. Be careful of precipitation. So here's a TPN order. Let's see, let me catch up with myself here. A little complicated? Most of all of this is done electronically nowadays. When you could write on forms, people did. It wasn't uncommon to transpose figures or check lipids when you really wanted carbohydrates. There was a lot of room for error in writing these particular orders. I'm trying to think which. Here this requires you to record the patient's height and weight. I really want to point out, though, the problem with the TPNs that we have today, even with the magnificent electronic medical records and things that we have, there is absolutely no standardization. Every single hospital can call it whatever they want to start with. So I can tell you that every single hospital is going to have different orders, different ways to fill them out. So in terms of standardization, not so much. It was told to me one time, tube feeding is pretty straightforward. I mean, you have certain formulas. You got 5 or 6 that you're probably generally going to calculate or use most often. Those are pretty easy to calculate. There's not a lot of changes that you're going to make in with that can or with that ready-to-hang formula. TPN, on the other, is totally different. You can change absolutely everything. So there's no standardization whatsoever. I've got some, do you have an Elmo?
We do.
Does it take very long to warm up?
No.
Okay, because I do have a couple TPN forms here. I'm find it on by me.
Clear plastic bags. I had those. Oh, when you were young. The math teacher had them kind of roll. Yeah. Roll. That's how we did calculus. This lady, she had like with stuff like stacks. She was taking it down. Pretty bad. Oh. That little like pin that was super skinny. Yeah. Really pointy. It was always blue or red. Yep. Black. So the only colors. Maybe green, but that's about it. So maybe black.
Okay, so here's one example of a TPN order form. Dates, timing, you put a patient label up here. This is when they had paper records. This would probably be revised to be some type of electronic form now. I'm going to talk about the types of infusions in just a second. But you see all the boxes? I mean, you have to check everywhere. If you miss one box, it could complicate everything. But you're going to have to basically tell the person making the bag or the person hanging the bag, do I want to do continuous, do I want to do bolus, or what have you. Then notice it says standard, and it tells you what that prescription is, and then you can customize as well. So if you didn't like the standard formula, that comes already made or what have you, then you would calculate what you want yourself. That's kind of a nice form. This particular form, I'll hide the name. I want you to look at that form for a little while and see who can tell me why this is an absolutely terrible form. What units?
All different.
Give me two different units.
Millimole, milliequivalent.
All right, millimole, milliequivalent, that's huge. One reason we can't standardize these in electronic medical records is some places use milliequivalent, some people use milligrams, some people use millimoles. You don't think that's not complicated? It is. What other units?
The 1 vial a day,
That's pretty standard.
really?
The vitamins and the minerals will, they'll either have 5 particular vitamins, another vial will only have 4. So that's pretty standard.
Grams per day, and grams per liter.
You win. You win. This is the worst TPN order form you can possibly imagine. Because I now have to figure my amino acids in grams per liter, I figure my dextrose in grams per liter, then I have to figure out my grams per day. Major mistake. Major, major mistake. Because you're gonna run this at 75 mils an hour or 100 mils an hour. You're gonna waste so much time calculating, is that per hour, or is that per day, or is that per liter? It's a huge problem. So, good for you for pointing that out. The order form that I sent around to everybody is my favorite. Anybody know why?
Nutrition consult ordered for all patients.
Yes, bingo. We don't wait for people to check that box. The forms are printed with that box already checked. Yeah. Absolutely, so that's my favorite form. Just thought I'd show you that. Today with electronic medical records, see if I go back to the, nope. I go back to the, is this added? No signal? No? Don't want to do power. Desktop? Do desktop? Yeah. Okay. Okay. All right, so yeah, if you do not have time, if you do not have the energy, if you don't have the expertise, you don't have to waste time trying to figure out what to calculate. Most of these will have a standard slow amount where you can check at standard, then have the nutrition consult marked. Let us come along, let us calculate the needs, let us figure out whether it needs more selenium in it or what have you, and we'll leave that information. So that's my favorite one. After we know how many calories, what our macronutrient, micronutrient breakdown is and all that, we have to decide again, are we going to run this continuously, 24 hours a day? Is this going to go through the GI tract? No. The liver's still never going to get a chance to rest though, because it still has to metabolize all this. So continuous, if you do this on a constant level though, you stand the chance of having a more stable blood sugar. So if you did it on something called a cyclic basis, this is an example of a cyclic order. A cyclic order means it's similar to nocturnal possibly. You could do it during the day if you wanted to. But a cyclic prescription is going to start at Slow rate of 75 mils an hour for 1 hour. It's going to run 10 hours at 150 mils an hour. You're going to taper down for that last hour. Only had it going for a total of 12 hours. So you can do it all during the day. I'd recommend you do it at night, however. Give the patient the freedom during the day to go to therapy, to have company, to go to the the swimming pool or whatever they need to do. Give them a time to do stuff during the day, and then they could run this at night while they're sleeping. So you've got two choices. The cycline's a little bit more like normal. We're usually awake 24 hours. We may not eat every hour on the hour like the cyclic does, but still it gives the liver a chance to rest. When we don't give the liver a chance to rest, you can't clear lipids. You're going to see all kinds of complications, so get ready for that. Multiple complications of parenteral nutrition. Probably the most important one is you're looking for infections. Sticking a needle in any vein and leaving it there for a period of time. The amount of bacteria and everything that's in the room that's on that patient, you're looking for problems when it comes to infections. The reason I put fatty liver up there is because the liver cannot clear all of those lipids, so they tend to accumulate in the liver. Major complication of TPN that's going to run for 24 hours is fatty liver disease. If you haven't calculated properly and you've got a fluid volume that's too large, you're going to have fluid overload, hyperglycemia, hyperlipidemia. If you can't clear those, triglycerides. If triglycerides go over 400, you need to get rid of some of that lipid in the back. The liver's not clearing them anymore. You need to take some of those lipids out. Thrombosis, the catheter can dislodge. It may be a PICC line, and that PICC line migrates. It starts to get further and further away from where it's supposed to be. Then you've got huge problems. When a TPN is hung, there are certain things that nursing should be in charge of or controlling for us. They need, once a TPN bag goes to the floor, it's got a label on it. That label is not, just like those order forms, are nowhere near standardized. So they're going to be different everywhere you go. But that should be validated. You should see a written order in a medical chart. You should compare that to the label before it gets hung for the patient, and that information should agree. If for any reason it doesn't agree, they shouldn't be hanging that bag. They're going to monitor the vital signs, lung sounds, monitor finger stick blood sugars. They're going to hang D5 if they need to stop it pretty quickly. Observe if white blood cells go high, if they start to run a fever, you're looking for whether or not you've got some type of infection. And most importantly, you really need to know the hospital protocol. TPN orders usually always have to be in by noon. The pharmacy is going to start compounding or running them at 1, and then everything needs to be hung by 6. So there's some type of a protocol. That protocol is going to include how often labs need to be ordered, monitored, weights, all of that type of information. So we already mentioned briefly refeeding syndrome. Here's the pathophysiology on it. If you feed too many calories, if you increase the carbohydrate, you increase insulin secretions, which causes an intracellular shift of electrolytes into the serum, and levels of phosphorus, magnesium, and potassium all go really, really, really low. So what we usually recommend is before we even begin a TPN, the patient should be hemodynamically stable. I'd like for that to be true. It doesn't always happen. But if you have a patient that has a phosphorus level of, let's say, maybe 3, and you infuse 3,000 calories over a 24-hour period very quickly, the shift, it's going to pull all the potassium out of the bloodstream and go inside the cell. What does the P stand for in ATP? Yeah, it needed all of that phosphate to make ATP. So throwing in that number of carbohydrates, having to make as much ATP, you just sucked all the phosphorus right out of the bloodstream, and you'd be lucky now to have a phosphorus of about 1. Not good. Not good. So that's refeeding syndrome and can do a lot of damage. Try to make sure that they're stable before you initiate that TPN. If you're worried about refeeding syndrome, sometimes you may not be feeding too much at all. If this person hasn't eaten for 7 days, 8 days, 10 days, anything is going to be a shock to the system. Start slow and creep up slowly. It wouldn't hurt to even start at 50% of what you think they need, and once they start to tolerate, once those lights are stable, then you can start to increase gradually. We always add 1,000 milligrams of thiamine for the first 3 days in these particular situations. What's thiamine needed for? It will prevent the deficiency. You'll have a deficiency if you have too many calories because thiamine is also needed to turn that TP. It's the TTP in the Krebs cycle, I don't know what they even call it, citric acid cycle, whatever those names are. So the minute you start adding more calories, you also need additional thiamine in order to metabolize them properly. So 100 milligrams of thiamine for the first 3 days. Then monitor, then you might be able to stop the thiamine. Bottom line, order the RD consult. If you don't have time, if you're busy, we like this stuff. We could do it all day long. We're all OCD. We love to do it. We'll calculate one any day. All right, in summary, any type of TPN, any type of parenteral nutrition requires a team effort. There's no one person that's responsible for everything. Assessment is key, knowing a lot about the patient, the history, the background, medical conditions, it does make a difference. Try to be as patient-centered as you possibly can. They may not want long-term feeding at all. They may want to die. You may have to honor that. So just because you can doesn't mean that it's necessarily right. And then monitor the heck out of it, because things can change on a dime. You have to be on top of it, you have to be on your game, you have to know exactly what you're doing. Make sense? Yes.
Are all hospitals required to have an RD? So like if you're out in the middle, if you're out in Blackwell, are you gonna have an RD or are you gonna, or do you have, I guess where I'm going with this is, is there like a number we can call if we need help because we don't know how to do it? How do we get access to one if we don't have one like readily available to us?
Smaller hospitals will sometimes maybe have an RD on consult or PRN. A smaller hospital, I don't know how aggressive they're going to be with TPN. Do they ship those people out? And so the smaller hospital may ship somebody out to begin with if they're that bad. But a lot of times the smaller hospitals, the dietitian will go there maybe once a month just to review some records or what have you. But part of the whole team idea or teamwork is that you get your hands on somebody's card, get your hands on a dietitian's information, call them if you need them. Absolutely. Absolutely. One of the hospital, I mean, I consult for Women's Lakeside Hospital. They don't need me there every day, but they hang my license. They've got my number. They can call me anytime they want. And I could answer a question over the phone. I can go there if I need to. So, yeah, there's a lot of those type of arrangements that can be done.
A lot of the county health departments have one, or they share one with several counties.
Yeah.
And so if you're going into a county you don't know anything, then that is usually a good place to find one.
What else? How many people are ready to calculate? Want to try TPNs? Live for TPNs. Never want to see a TPN. But they're really not bad. I mean, when you do them, if you're on the IC floor, you're there every day. I mean, it becomes just as easy as making brownies, you know? You do it all the time. You don't think twice. You can do them in your sleep almost. So, it's not bad. Other questions? Now's your chance. Anybody gonna call me when you drop your first tube? Will they let them drop a tube, do you know?
I don't know if that's in their scope of practice or not, I'm not sure. I would imagine so.
when you really get into the patient care side of it, when you really get the opportunity to know you can make a difference, you'll want to do it. So, you just have to jump in. Don't jump back, jump in. That's all I've got, unless they've got some questions.
Thank you very much.
You know what?